Hello, everyone. My name is Sruthi, and this is Dinara and Evan. Our presentation is a guide for practicing clinicians on doing therapy with elderly patients. Here's a quick overview of our presentation. We'll begin with some background demographic information on elderly people in the United States. Then we'll explain why this training is important before moving into issues that therapists can face, including things like elder speak. Furthermore, we'll discuss how biases against elderly patients can work against them. After, we'll go over a counseling method that focuses on strengths of elderly patients, and then we'll leave you with some training resources to help your current or future clients.
So let's talk about the demographics of this population. The number of people ages of 65 and older is projected to grow significantly from 9% today to 16% by year 2050. And in the US, this proportion is even higher, reaching over 23% by year 2060. That means that one of every six people globally will be age 65 and older by year 2060. Why do we have this phenomena of the aging of the global population? It is because people are living longer, the mortality rates are declining, and fertility rates are going down as well. Among this population, approximately 20 to 22% meet the criteria for a mental health disorder, which is actually less than the general population, because the prevalence of mental health disorder tends to decrease with age. So when we look at it by gender, older men tend to have higher rates of substance abuse and personality disorders, and older women tend to have higher rates of anxiety and depression. And compared to younger population, there is comorbidity with physical health problems, which are just more common later in life. Things like neurocognitive disorders due to degenerative brain diseases and stroke, sleep-wake disorders, chronic pain, suicides, all of these are much more common later in life. All of this is to say that the demand for psychological services for older adults is already high, and we expect that it will continue to increase in the next many years. Some other trends we wanted to share that are kind of newer and supported by research. One is that there is increasing comfort with technology among older adults. So, for example, at least 75% of older adults are internet users today in the United States. And just look at this increase in telehealth usage from less than 5% pre-COVID to over 20% now. The other trend is because we have improvements in curability of previously terminal diseases, increasing lifespans, and adoption of things like mindfulness and meaning-based living, all older adults have been able to actually contend successfully with myriad of potential losses. They continue to find unique possibilities for achieving reconciliation, healing, deeper wisdom, harmony, and many older people maintain positive emotions, which only tend to improve as they practice more of it, and they continue to enjoy, many of them continue to enjoy high life satisfaction. That said, it is important to talk about the importance of training for therapists, because serious mental health disorders do occur, of course, with older population.
So let's focus on the importance of training. So as of 2019, only 1.2% of practicing psychologists specialized in geropsychology. Yet 37.2% of psychologists reported seeing older adults frequently or very frequently. Now, it is important to note that according to the Pikes Peak model for geropsychology training, highly specialized training is not necessary for all clinicians, as many older patients will be similar enough to younger patients, and the clinician should have the capacity to do competent work with them. However, when more complex and specialized circumstances arise, greater levels of competence in geropsychology are required. Some examples of these circumstances include the potential presence of dementia, complications from comorbid medical problems, the need for assessment of decision-making capacity, and providing nursing home consultation. Considering the statistics Tanara previously mentioned on this rapidly growing population, and the very small number of specialists in the field of geropsychology, the potential for clinicians to unintentionally cause harm to their older patients, both now and in the future, is high and will continue to rise unless greater confidence and interest in working with older adults is achieved. A study done in 2009 found that when social work graduate students were presented with learning materials and case studies highlighting the vitality of older adults, they showed a greater interest in working with that population. This highlights the importance of incorporating geropsychology into graduate schools and training programs to increase interest in working with older adults while actively combating negative stereotypes around aging.
All right. Next, we wanted to talk to you about the importance of attitudes and beliefs of mental health professionals when it comes down to working with older population, because they significantly impact the assessment and treatment of older adults. So let's look at a couple of the following attitudes. So one is a caring and supportive attitude. Of course, being caring and supportive is very important for therapists because the client rapport depends on it. However, research shows that being too caring and protective is therapeutically obstructive for older patients because it leaves them dependent on help. So when young therapists protect these patients, the therapists themselves might be at a greater risk of feeling personally responsible for older adults. And that, of course, impacts the therapeutic process. Also, an overly patronizing behavior could also inhibit patients' autonomous capacities. So in this context, it is important to recognize that older individuals have the right to make their own autonomous choices. And the second one is the attitude is being doubtful. So some young therapists may feel hopeless and helpless when they work with older patients that are, especially those that are depressed or severely ill. So it can occur because the patients themselves can question their own potential for change. And also, there are stereotypes of older people being inflexible and resigned, which can be projected into therapy. And also, some young therapists might consider inside-oriented therapy approaches as less important and less appropriate for an older patient. So the recommendation for young therapists is to reflect on personal doubts, feelings related to old age, and not to be too therapeutically distanced or ever express their personal hopelessness and as a frustration or aggression towards older patients.
So let's talk a little bit about elder speak. So the stereotype of older adults being less competent can trigger a change in speech patterns, and that is commonly referred to as elder speak. It is most often heard in communication between younger and older adults. It's frequently heard in healthcare settings, and oftentimes can be indistinguishable from baby talk. Elder speak can be identified by a slower rate of speech, exaggerated intonation, elevated pitch and volume, greater repetitions, and simpler vocabulary and grammar when compared to normal adult speech. Other indicators of elder speak include diminutives or inappropriately intimate terms of endearment, such as honey or sweetie, inappropriate plural pronoun use, such as we instead of you, and tag questions, which prompt the answer to the question and implies that the older adult can't act on their own. Although elder speak can be considered an attempt by the clinician or practitioner to show care and empathy and to promote clear and effective communication, unfortunately, it is oftentimes perceived as the opposite by older adults. Ultimately, elder speak is perceived amongst older adults as patronizing and implying incompetence, and it does not improve comprehension of speech for most. Instead, elder speak may cause older adults on the receiving end to respond with lowered self-esteem and depression, while simultaneously reinforcing dependency and may even contribute to an older adult's physical, cognitive, and functional decline.
The first thing to do when working on biases is to examine your perspectives on elderly clients, their abilities, their goals, their rights, etc. You need to understand that elderly clients come into therapy with a variety of needs that may or may not include coming to terms with their life and death. Mental illnesses such as depression and anxiety are not just part of growing old. We can and we should treat them. It's important to know when you can provide support, but not become the client's entire supportive network. As always, seek out supervision and consultation if you're needing advice. Lastly, Pikes Peak has a geropsychology self assessment tool to determine your level of competency that may be helpful. Additionally, here's some more information on when discussing biases against elderly people. It's important to remember all of your basic therapeutic guidelines, such as maintaining openness and developing rapport. We want to treat each client as an autonomous individual with an incredible capacity for change.
So, with all this in mind, now that we understand the negative impact of elder speak when working with older adults, let's focus on how to overcome it. One of the best ways to avoid using elder speak is to become aware of our own biases and stereotypes around aging. In addition, we must become aware of our own speech patterns when communicating with older adults. It is also helpful to pay attention to moments in which younger and older adults are interacting in everyday settings, like the grocery store or at the bank, to practice recognizing when elder speak is being used. In more clinical settings, we can rely on the communication enhancement model, which emphasizes that we must address our older patients' needs on an individual basis and to rely on simplification and clarification of speech only when deemed necessary. This way, older adults with intact cognitive and communicative abilities will receive messaging that affirms their functional abilities and reinforces their strengths.
One way you might work with elderly clients is to consider their strengths and work from that perspective. Recognize their spirituality and resiliency, and you help them focus on sustained well-being and coping. It's important for elderly people who have experienced a lot to transform negative events into opportunities for personal growth and life satisfaction. One of the base principles of this perspective is that people are able to direct their lives more than they realize. Giving elderly clients an internal sense of control helps them better utilize their pre-existing resources for problem solving and healing.
So, for some additional training resources, the Council of Professional Geropsychology Training Programs has a wonderful website that is full of resources for everyone from graduate students to post-licensure clinicians. These include the Pikes Peak Geropsychology Knowledge and Skill Assessment Tool that Sruthi previously mentioned, online resources including a collection of conferences and workshops and web-based training opportunities, additional books and journal articles, and even one-on-one consultations. Thank you everyone for following along, and we hope you find this information useful and that it increases your awareness around serving a vulnerable population on the rise.